నిన్న చూసారు, ఏమైంది పెడుతున్నారా? ఈరోజు పర్లేదు అన్నట్టున్నారు కదా.
Hi, Dr. KV, welcome.
Good afternoon, sir. Thank you for warm.
Mute lo undi. Your mic is in mute.
Now is it audible?
Hello?
Hello, is it audible?
Yes.
1 minute. Ikkada volume.
Am I audible?
Yes, sir. Yes.
Sir, you are audible.
Yeah.
Thank you. Welcome all.
Yeah, it is clear.
Welcome, Dr. KV.
Thank you, sir. Thank you for welcoming. Happy Swallowing Awareness Day for all.
Good afternoon, sir.
Good afternoon. Good afternoon.
Dr. Premnath, sir.
Good afternoon.
Good afternoon, sir. Have you joined? Yes, yes.
I'm there. Sharp 2 o'clock. I started.
Yes, yes,
joining.
sir. You name actually iPhone ఉంది కదా అది అర్థం అవట్లేదు.
iPhone. Okay. Yeah.
Yes, okay, sir. I think we are waiting for Professor RKP, sir.
Yeah. Just now joined, Professor RKP.
I joined.
Yeah, just now joined.
Very good, very good. I will make him as a host. Sir, Rajendra, sir.
Yes, are you able to hear?
Yeah. Shall we start, sir?
Yes.
It is audible.
Yeah. I think it is audible, sir.
Clear. It is clear.
Not audible, sir, clearly.
Hello. Yeah. Yes, Dr. Nagar, is it audible?
Yeah. Little better, sir, but not very clear.
Okay. Okay. Please keep the Wi-Fi strength and etc. So, shall we start?
Yes, sir. We are all
Yes.
with you.
Okay. So, Om Jai Ganapati. Good afternoon to everyone. That today we have assembled to this webinar for the wonderful
Some interruptions are going on.
Activity therapy as well as followed with evaluation patterns for correction of swallowing disorders and disorders, which we correct through our speech language therapies. So today, as we know, the day of swallowing day awareness, which I feel it is not only for the general public, also for the associated professionals and professionals such as speech language pathologists at different degree, that is at BSLP or MASLP, and higher BSLP. we have to sensitize the general public about these disorders by which our profession will get importance. So when there is a problem in voice, when there is a problem in articulation, when there is a problem in swallowing, when there is a problem in various language disorders, have to
Excuse me,
meet
sir.
directly to this language.
Rajendra sir, excuse me, sir.
that is
Voice
how-
clarity is not there, sir.
Okay.
Wi-Fi is there, sir.
So-
Please connect to Wi-Fi. No?
1 minute. 1 minute. I will connect through mobile. I think
Yeah.
it will be better.
Because it is interrupting, sir.
Give me 1 minute. Please connect it to me.
Yeah. Okay, sir. Please carry on.
Yeah.
Recording in progress.
Oh,
Yes. Are you able to hear now?
sir, since you logged in two systems, no interruption is coming, sir. Please switch off the mic in one system. Yes. No, you muted, sir.
Yeah.
Right.
Once again, good afternoon and welcome to all the dignitaries as well as participants for today's program, that is Swallowing Day Awareness, which is celebrated on 16th March every year. So as a speech language pathologist, we are very proud to celebrate these kind of events and occasions for the general awareness that is very much important in between both the general public and as well as for the core professionals such as speech language pathologists and other team of professionals who deal with the speech and hearing allied sciences. So, and today, as we know that we have various speakers who are talking about anatomy of swallowing disorders and as well as physiology of swallowing and its disorders, and as well as the case presentations are also done. So today it's a privilege to conduct this kind of events through our Telangana Audiologists and Speech Language Pathologists Association in association with other institutions of Hyderabad and as well as UCA, that is Universal Association of Clinical Audiologists. So this platform, we are going to discuss the very much valued topic today about these swallowing disorders, that is dysphagia. As we know, this is very costly, what we call course, which is provided by different institutions, such as fellowship and as well as course and short-term training programs, and as well as what we call the workshops all around the India and other countries. So through this platform, we are conducting with free access to all the participants and speech language pathologists, qualified audiologists and speech language pathologists to attend this. And really, we Telangana Association welcome you all, and we are obliged to provide this opportunity to you. So without wasting much time, I call upon our the chief guest for today's occasion, that is Dr. Nagendra Kankipati, who is the founder and the present president of the Telangana Audiologists and Speech Language Pathologists Association, as well as Universal Association of Clinical Audiologists. Now, sir, it is over to you, Dr. Nagendra.
Thank you, sir. Very good afternoon to everyone. First of all, happy Swallowing Awareness Day to each one of you. And as in recent times, the awareness of swallowing is becoming more and more. Public also getting more awareness, and every day I am getting calls for a speech language pathologist and swallowing therapist. So I congratulate all the SLPs who are working very hard and who are providing dedicated services in this area. the specialization of the swallowing is becoming more importance nowadays, and our EC members, respected advisor Dr. Premnath Balla sir, and our EC member Dr. KV Narayana Garu and Dr. Gangaraj Garu, all are providing wonderful services in the swallowing disorders. So on the occasion of this Swallowing Awareness Day, we would like to conduct this webinar. I hope you all will thoroughly gain knowledge through these presentations and also will enrich your skills. And regard, I just want to share one slide with all of you. Just one share. Maybe there is some problem in the sharing. I will just show you, read out something. I just found one good important thing today morning only. It is issued by the Swallowing Awareness Day. The theme of this today is a difficult diagnosis to swallow. People swallow 700 per day. It is the poster is telling this. The swallowing uses 26 muscles, and also one in 17 people will develop some form of dysphagia in their lifetime, and 15 to 30% of people aged 65 plus living in the community with this swallowing problem, and 50% of older adults in nursing homes are suffering with this swallowing problem. And so many statistics are there. So it is clearly indicating that there is a major role of speech language pathologist to help the patients in swallowing disorders, in the management of swallowing disorders. Once again, I wish you all a happy World Swallowing Awareness Day. And thank you so much, Professor Arke, sir, for giving me this opportunity. Thank you.
Thank you. Very good that you have presented the theme of the today's importance. And I request now our General Secretary, Honorable General Secretary, Imad Khan Ruman ji, to please address the gathering. He is also founder member for our TASLPA Telangana Audiologists and Speech Language Pathology Association, and as well as UCA, that is Universal Association of Nasal Audiologists. Now over to you, Dr. Imad Khan Ruman.
Hello, good afternoon, everyone. I hope you all are having a good time. So recent times we have seen several webinars because of the COVID period that time. And also now again we are seeing after a long time we are again come back in webinar after completing successful physical TASLPA con. So I wish you a very happy Swallowing Awareness Day, because swallowing has become a very big reason for speech pathologists. In the recent times, I have seen the recent studies. So approximately 14 to 18% people who are hospitalized for some reasons may need a specialized swallowing specialist. So I was going through NCBI website today morning, so where I could found that if 14% people who are hospitalized, if you see in India, more than 5 lakh people are hospitalized every day. So this swallowing is becoming a very big problem, and also government also is working in their sectors. At present, there are so many specialized audiologists and speech pathologists who are working for this cause. So we thank all the members who are joined. We thank all the speakers who have taken their time and they wanted to be practical this today meeting. They have come up with so much of efforts to help us about swallowing. So we thank you all the speakers, and also I thank our program coordinator, Dr. Rajendra sir, for providing me the opportunity to speak in front of you. Thank you so much. And now
Thank you.
Thank you, sir.
Thank you very much, Honorable General Secretary Imad Khan,
Thank you, sir. Thank you,
for
sir.
providing the statistics also and the importance of the speech language pathologists in doing this vegetative and non-vegetative repair of dysphagia, that is swallowing disorder. Now, this is time to call our guest of honor, our Assistant Director in charge, Dr. B. Srinivasa Rao sir, to please address the gathering.
Hello, am I audible?
Yes, sir, you are audible.
Yeah. Thank you, Dr. Rajendra. Right. So, on the occasion of the International Swallowing Day, I am very happy to know that the TASLPA organizing such a wonderful webinar on the swallowing disorders. So the organizers, Dr. Naginder and Dr. Imad Khan and Dr. Rajendra, and also the resource persons of today's webinar, Dr. Premnath Balla, Dr. Venkat Narayana, and Dr. Gangaraju. So I appreciate all of them for coming forward to give a talk on the importance of swallowing, the basics of swallowing, the anatomy and the function, the physiology of this swallowing, and also the assessment and treatment of the swallowing disorders. So as said earlier that as we are moving more towards Western culture or Western lifestyle, right? As the even regularly, Dr. Rajendra keeps on posting in WhatsApp groups about the importance of the good diet and the importance of hitting the ground every day, right? So one has to live the sedentary life, right? And doing the physical exercises keeps everyone healthy and reducing these kind of systemic disorders like these days, the incidence of CBA is increasing and is one of the primary cause of the deaths. So, I say you are what you eat. If you have to eat properly, right, you're chewing, you're swallowing, and the digestion has to be very good. So, on this International Swallowing Day, the NHS, as part of the Nutrition and Hydration Week from March, celebrated from March 14th to 20th. So it is also called to observe the Swallowing Awareness Day on March 16th. So earlier said, any human swallows around 500 to 700 times a day. So any difficulty in the chewing or in swallowing, so or while eating or while drinking, so it can cause these swallowing difficulties and is also known as dysphagia. So this causes issues with sucking, chewing, eating, controlling saliva, taking medication or protecting lungs from food. So if there is a problem, it can cause aspiration and it can also cause death, and drinking going the wrong way. So ultimately, what it means is food, drink, or saliva into the lungs, causing a lung infection. So swallowing disorders that affect these essential function can happen at any time of our life. So the aim of observing this particular day is to spread awareness of this condition among the common public. So usually the signs and symptoms of dysphagia are, so taking a long time to chew, food getting stuck in the throat, changes in voice, including nasal or wet speech, difficulty chewing or controlling food or fluids in the mouth, coughing or choking when swallowing, changes in eating habits such as eating slowly or avoiding meals altogether, significant unintended weight loss, recurrent chest infections or pneumonia, food or drink coming out of the nose when swallowing, and also anxiety when eating, drinking, or swallowing. So, like the TASLPA is always striving to increase the awareness about audiologists on World Hearing Day. Like there are posters. What do you say in the posters? If you have any problem with your hearing, please approach the nearest audiologist, right? So we should also say that any problems in this kind of swallowing, right? So please approach the speech language therapist, right? So on a whole, so I once again congratulate the organizers and also the resource persons and all the participants. I wish them I give my best wishes, and they will have a wonderful lecture. Thank you, the organizers, once again.
Sir,
Thank you so much, sir.
Right.
thank you very much, sir, for enlightening the importance of speech language pathologists and the daily routine activities should be done by the any individual, and also the what we call the awareness modules which are taken, and the works which are taken by TASLPA to reach the public and to reach the unreached. So this way, we are very pleased, sir, for motivating as well as coming and honoring this occasion. And we are very pleased that our institutions of all Hyderabad 4 institutions are coordinating along with us in different activities. We welcome you, sir, once again, and thank you very much. Please
Right.
continue this kind of service so that we can really get importance of speech language pathology field individually, not depending on the other professionals. So thank you very much, sir. Now I invite the first speaker, that is elder speaker, our Premnath Bhalla sir, who is not only a MASLP, that is MSc Speech and Hearing and MSc Audiology and Speech Language Pathology, who has done his education in Swikar. He is alumni of Swikar, where he did BSc HLS and as well as MASLP, and he also is a recipient awardee of fellowship in neuro rehabilitation and FGA, and sir is a medical audiologist and speech language pathologist and neuro rehab specialist. He is a clinical director for Phoenix Multi Specialty Medical Rehabilitation Center, Jubilee Hills. He has provided world-class treatment for autism, speech, voice and hearing problems, stroke rehabilitation, swallowing problems, neurological disorders in both children and adults. Sir was a former consultant in Gandhi Hospital, Secunderabad, and ENT Koti Hospital, and honorary consultant at NIMS Panjagutta, Hyderabad. And in his 19 years of career, he has seen different variety of patients across the world and given several TV interviews to create awareness in public related to healthcare. And sir was felicitated with many awards, that is in 2015 with the Nehru Excellency Award, and in the year 2016 Vaidya Ratna Sri Award from former Home Minister Sri Nayani Narasimha Reddy Garu, and Vaidya Ratna Award, 10 TV Award from the different dignitaries, and as well as in 2019 he was awarded with the Best Doctorate Award from the former Tamil Nadu governor. And he has conducted many medical camps, and he is our respected advisor and the beloved elder and teacher who guides us and who backs us in all the difficult and all the Herculean tasks where we have done successfully with his blessings. Sir, now I request Premnath Bhalla sir to please continue your talk.
Hi, good afternoon, everyone. Good afternoon, dignitaries and Professor Dr. RKP, our Honorable President, Dr. Nagendar, and Honorable General Secretary, Dr. Imad Khan Rumanji. Okay, first of all, I wish on the special day, 16th March, World Swallowing Day, and I congratulate my other presenters also, Dr. K.V. Narayana and Dr. Gangaraj in this aspect. So, first beginning of my presentation, I
Sir,
don't,
sir,
I
sir,
want to,
excuse me, sir. Video is not
Yeah.
there, sir.
yeah, I'm
Video.
actually power, just now power has gone. So I'm in
Okay,
that situation dark. That's why video I have switched off. Video.
Okay.
I kept
Okay,
mute.
sir.
Okay.
Yes, sir.
So I want to welcome Dr. K.V. Narayana to present about the anatomy of the swallowing issues. Hello, anatomy of the swallowing mechanism.
Sir, this is to introduce regarding the our honorable EC member, Dr. Venkat Narayana. So when it comes to the Dr. Venkat Narayana, I am audible, sir? Yes.
Yes, yes, sir. Please.
Yes, it is audible.
Yeah, Dr. Venkat Narayana is alumni of our AYJ NIFST who has done MASLP here and who has got 1 decade of experience and has solved many cases with swallowing disorders and feeding cases. And he is the what we call renowned speech language pathologist, and particularly in dysphagia. He has done various cases. Now and he is also, as I said, he is also our honorable EC member. So now I request our Dr. K.V. Narayana to please continue with the talk.
Good evening to all. Am I audible?
Yeah, please.
Yes.
So good evening to all. My name is Dr. K.V. Narayana. So I wish all of you a March 16th Swallowing Day Awareness Program. Welcome you all. So today I discuss with the topic of dealing with dysphagia and the case presentation. So before going to the discussion, so I am here to explain generally what is a swallowing and normal swallowing in the dysphagia. Just observe the video, and after that I'll discuss some more things. First, you are going to see a normal swallowing. How could be the normal swallowing will appears. Then later, sometime you can see a dysphagia connections. Till now you have seen the normal swallowing. Now you can observe more deeply into dysphagia issues. Yeah, the food is falling into the esophagus, like the lungs area where it is going to lungs.
Dr. Venkat Narayana, louder.
Yeah, the food here is going into the lungs area where you can see that it will get this difficulty in swallowing. So now my topic, like I'll come to conclude, like anatomical difference between the adults and the neonates. I'm more focusing on the neonates or infants dysphagia issues, swallowing issues. So first of all, I would compare both adults and the neonates as structural formation for the swallowing. So generally we know that a newborn to 4 weeks of age, we call this a neonates. In neonates, there is a difference of gastrointestinal system. So when coming to the children's, there is a large tongue. As you know that there is no space in the mouth. The oromotor structures will be very small and the space is very less. So the tongues will be larger in size. And nasal and oral passage are small when compared to adults, because clear nasal cavity and oral passage will be very clear for the adults. And coming to cardiac sphincters is relaxed in the stomach of the children's, but it is very tight in the adults. And children's every 2 to 3 hours they'll empty their stomach, because they'll take the food in very loosey form. Food passage is very rapidly in infants and very slowly in neonates, because they take only Cerelac or milk or something like that. So that is the reason that it will be very loose. And the infants' food passage into the stomach will be very fast. Where compared to the adults, it will be very slowly, and absorption take place more time, and hard stool will be there. So why? Because the adults will take, like example, they'll eat in the night and they'll go for stool for in the morning hours. So it will be long time. But when compared to children's, it will take 2 to 3 hours. Every 2 to 3 hours, they'll empty their stomach. And coming to liver is the 4% of the total body occupied in the abdominal cavity of the children, and only a little space is occupied by liver in the adults. So this is about the gastrointestinal system. This is talking about the starting from the mouth, it enters into the trachea and all, it's goes into stomach, and then it is urination. So I'm step by step is coming. Next is respiratory system. Respiratory system plays a major role in swallowing. So when we swallow something, food, or when we eat something, or when we deglutize something, the respiratory system plays a major role. It will to hold the breath so that we can able to swallow food properly. There is a comparison like in neonates and the infants, respiratory tract is very delicate and do not produce mucus. But some older children, they will have some mucus. In neonates, because we are already giving some food in a soft way, in a Cerelac and all, so that the food goes directly into the mouth, because they can't produce able to mucus. But at certain age, the children are able to produce mucus. That is the reason will increase the quality of the food and quantity of the food. The structural size and difference will be increased. But coming to adults, it's very well developed issues. So there is no much of problem food taking intake. And coming to ejection tube, it's straight and short in distance between the trachea and bronchi. Why the ejection tube plays here is the ejection tube plays a major role in maintaining the balance of air, the respiration from the outside surroundings to the inside of the body. It make a balancing system. So when taking some food and all, the ejection tube plays a major role. So this is very much longer in the adult. Coming to the tonsils and adenoids are larger during the childhood and involved in the production of antibodies, and smaller tonsils in the adults. The tonsils and adenoids in larger in children because there is a small occupied mouth. The structure is very small. There is no space inside the mouth. So, and these tonsils will appear more. So that's the reason we'll see most of the children, most of the kids will have a problem with the tonsils and adenoids because of structural formation itself is from the neonates very small. As age increases, this will get down. And respiratory tract obstruction occurs commonly in children because of short airway, because they have the short airway passage. So respiration obstruction will be there. That is the reason we'll give in a small sips of water, small sips of milk and water, the Cerelac and whatever the things we are giving to neonates and infants. We get a small quantities so that the airway tract should not be just obstructed. And coming to less chance of obstruction in the adults. And the respiratory rate is more because the children have more, they take more short breaths of respiration more. The respiratory tract needs step-by-step respiration while they are eating, when they're swallowing and all. Whereas adults, it's less. So here you can see some picture I can show you. This is what the pediatric swallowing tract area, and this is like adults one. The space is very small and very U-shaped structure you can see, but adults come into very big epiglottis and there is opening of the vocal folds can be seen. So that structural size, that is the reason area respiratory tract is very small for the pediatrics when compared to adults. And the structure will be like this. Is a graphical representation, like, the adults will have the cylindrical shape size of cardiac and laryngeal movements, and the respiratory tract will be there. But coming to the children's, infants, it will be funnel shape because of the, fully not structurally formation. So the elongation of the neck will be very short. So that is the reason it will be like bending type of, you can see the funnel type of laryngeal structure we can observe here. And heart and circulatory systems plays a very major role in swallowing, especially children with heart, like, high pitched sounds. We can clearly hear the sounds if we can able to, like, feel the sounds of the heart. And pulse rate will be 140 BPM, means this pulse rate will be low for adults, 80 to 90. BP lesser than adults is 100 per 60 mm, and adults will be 100. Here we have to observe in children's while giving feeding. This place, this, like, in the hospitals we set up, we can see there is a, like, setup of ICU setup. There is a monitor. In that monitor we can see saturation levels, SpO2 level, pulse of heartbeat, and there is a blood pressure level. Some children, if somebody's got affected because of some other medical conditions, well, when we are giving feeding and when we are giving something, milk or any food, like and all, this pulse rate we need to observe very much. In some children, the pulse rate will goes very much down because of the pulse rate, the blood level pressure will get down. So we need to observe that, take care of that. In some children, because of breathlessness and all, the BP will goes high or sometimes fall down. This we need to maintain very carefully, very consciously. We need to deal with the kids. Whereas adults, it's not a big issue. They can able to understand. They can able to swallow normally. If there is any problem, we can able to manipulate him. But children can't say to us. We should more focus on the monitor that present in the hospital, in the NICU setups in the hospital. So this is very important, plays a major role while feeding. Keep an eye on this. So there is a comparison airway tract difference between the adults and the children. So there is, you can see there is a blurred video, but I can say there is a narrow nostrils for the kid because very small nostril opening for the kids, and newborn obligate nose breathing. Most of the kids will go through nose breathing because when they take the milk from the mother, they'll always the nose plays a major role in taking a breathing control. And occipital is rounded. Tongue is relatively large for the mouth, as we know that. Why? Because the structural, oromotor structural, open structure and buccal cavity will be very close to each other. There is no space. That is the reason the tongue will be appear to be large. And epiglottis is omega shape and flappy. And larynx is higher in neck. You can observe this around C3 and C4. We can observe this larynx will be high in neck, and vocal cords are in anteriorly placed. And very neck is, as I said, neck is because short. That is the reason that tract that passes the food is will be very short, and precord rings are narrowest in diameter. These are the major difference that we can observe. So this laryngeal tract is like around C3 and C4 in children and neonates, but C4 and C5 up to C6 mostly that area will be larynx will get intact. So there is integumentary system, means that the balancing system of the body from inner side to outside during the swallowing, and it plays also very major role. This is just I'm giving here. So accumulation of vernicosia and in neonates and infants by sebaceous glands. This plays major role, and in adults it is in the form of the sweat. It is from the sebaceous glands are larger in size, and adults are small. Tinea capitis in early childhood and tinea pedis in adolescents are common and uncommon in adults. So hair is skinny and silky. These are some features that we can see in the kids and adults. Now, lastly, coming to the urinary system also plays a major role. If some of the kids will not urinate, does not pass away, they feel very uncomfortable. They will cry, and their BP will get shoot up. Their heartbeat will increases. So this is also plays a major role. Whenever the doctor comes or whenever the swallowing specialist comes, the first question is, how is the kid and does the child has passed the stool or not? Then only they go for the further treatment. So this is very important tip that we need to work it out. So infants or toddlers doesn't have control over the urination because they go whenever the time they feel that urination is there, then will pass the stool and all. And bladder capacity is too less and influenced by the stress and does not. So these are the anatomical structure, gist of the anatomical structures from starting from the mouth to the end of the urinary tract, from the respiratory tract to the oromotor structural tract to the urinary tract registration. Now, this is the overall gist of the anatomical structure comparison of children with adults. Now, I request Premna sir to speak on this physiology of the respiratory system and swallowing system. Hello.
Hello.
Yes, sir. Now, thank you, Dr. Venkat Narayana, for providing best regarding the. Hello, I am audible, right?
Yes, sir. Yes, sir. Audible.
Yes. Thank you very much for providing the very zestful and very comprehensive talk on the anatomical aspects of swallowing and dysphagia. Now, as I mentioned earlier, the next speaker is going to be our respected advisor, Dr. Premnath Balla sir, who is also a fellowship recipient in neuro rehab and as well as alumni of speaker, and has got several awards, Vaidya Ratna, and many best doctor awards and many other awards, as I mentioned earlier. So now it's a time to welcome you, sir. Dr. Premnath Balla sir, please start your proceedings.
Thank you, Professor Dr. RKP, and thank you, Honorable EC Member Dr. K. Venkat Narayana. Excellently have presented. Okay, all the aspects of anatomy you have covered in both the adults and children. Now, first of all, you all have to excuse me because slides, mainly especially PPT presentation, I couldn't do because of my laptop under service. But the total mechanism I want to explain in brief and in detail also. So first, let us know the actually swallowing mechanism and how it involves the passage of a bolus of a food, both solid and liquid, from the oral cavity to the stomach via the media is a pharynx and esophagus. And everyone know it is a partly reflex and
Sir,
it is sometimes under voluntary.
Sir, sorry
Yes,
to
tell me.
interrupt. Please keep your video on.
Yeah, it is a power interruption, total dark. I am sitting in the complete dark. That's why I kept it on mute and I am speaking.
You can open through your mobile so that we can.
Mobile only. I'm using 1 minute. I'm using my mobile only.
Please come towards
the complete my cabin became dark. That's why. So my face may not be visible. That's why I kept it video on the mute and I started speaking.
No, sir. Please try to keep so that it will be more comprehensive. Try to come towards.
Sure. I will try my level best now. Now.
Yes. Come towards light so that you can appear.
Is it okay? Clear? Now, okay. Is it okay? This is what the okay.
Come closer. Come closer to the window. Come closer to the window.
Very close. Very close.
Window.
No, I opened complete. Okay, this is near to ICU actually, my cabin. So it is when. Hello.
Yes,
is
sir.
It audible?
Yes, sir. It is audible. But if light is there, that would be very much good. So please come towards the light source.
I am 1 minute. I'm trying.
Outside also you can come since we are going to talk.
Hello.
Yes, sir.
Yes. Okay, I don't because here because of heavy cloud and wagera, power interruption. One more lot of disturbance outside. I have gone and I have seen lot of air disturbance is there. My speech, my voice may not be audible very clear. That's why I was completely closer cabin. I am sitting and
one idea I will give you, sir.
Answer that is fine. No?
Make your flash on. Make your flash on. Flash on.
Flash.
Mobile flash on in a room so that it will improve the light. Mobile torch, you can also tell.
1 minute.
Little audible, sir, now. Yeah, now visible, little visible.
Okay, fine, but okay, whatever.
Yes, sir. Continue, sir.
So that is what swallowing is the very critical mechanism. Though it looks very simple, but the entire mechanism is very critical and very complex action, which requires a completely extremely precise coordination between muscles, between nerves, between the organs. So, as I said, it is comes under the partly reflex action and voluntary action too. The reflex action, it will be voluntary action when it is at a oral level, oral stage, towards the back of the tongue. But when it is into the pharynx, automatically reflexive action starts towards the esophagus level. So that's why three phases we tell generally at a nasopharynx level, at oropharynx level, at a hypopharynx level. And the cavities, mainly structures involved in the swallowing, main aspects, the nasal cavity, hard palate, as usual, soft palate, tongue, epiglottis, and esophagus, and even hyoid bone. And whereas if we consider oral stage, which is a completely under voluntary control. That's why whenever we see difficulty in swallowing in the patients, first we should not make them rush and hurry. We have to explain them very slowly, if possible. We'll try to chew in front of them, taking a piece of biscuit, we'll put in the mouth slightly. Only the thing we have to request the patient, very keen observation you have to do, because swallowing, when it is very easy, when everything works normal, intact. It will be such a difficulty when, if any nerve, mainly especially cranial nerves, if gets affected or any kind of neurological condition disturbs, so it is a really critical, and those patients gets anxiety. In that anxiety, stress develops and all the wrong things and wrong way of swallowing occurs. And in fact, pulmonary aspiration may occur, which may cause mortality. So that complex activity it is. That's why very carefully, whenever we have to explain a proper physiology to the patient also, how easily and how time taking, but it should not give any kind of difficulty or stress or any hurry. If any kind of choking action or reflex action we are seeing, immediately we'll ask patient to stop chewing, stop swallowing, because once the food enters into the pharynx and esophagus, almost reflex action and involuntary action. So patient can't control, and it will give trouble. In fact, if it touches wrongly to the trachea also, then patient gets a lot of cough and choking, and definitely again pulmonary aspiration plays a major role, and critically oxygen supply will lack. Anything may happen. Means again oxygen supply to the brain if lacks, so again stroke may occur, many other major complications may occur. That's why this much carefully we have to deal with the patients with swallowing difficulties, swallowing disorders. Whenever we start to see the swallowing difficulty patients, we have to understand whether it is a neurological or physiological or psychological. If neurological, then we have to understand what kind of condition it is, whether due to the stroke, cerebrovascular accident, or because of after post craniotomy, because of in TBA cases, craniotomy occurs. Because of that, or any kind of cranial cerebrospinal fluid accumulation, any kind of hydrocephalus kind of thing, or any kind of genetical involvement, all these conditions we have to think. And apart from that, obesity also playing a major role nowadays. Obesity playing a major role. Because of that, the people are having blood pressure. In that kind of hypertension situation, the chewing mechanism itself very fast. So food won't prepare. The preparatory stage itself gets disturbed. In that stage, if tongue pushes the food, behind that, means towards the pharynx level, automatically the majorly obstruct will happen. So again, choking or difficulty, or they need immediately water. So that's why chewing plays a major role in swallowing aspect. So apart from that, you all have to know mainly swallowing, as previously our Honorable President Dr. Nagendra mentioned, 26 muscles are involving, but core swallowing involves only 20 muscles in the area of mouth, throat, and esophagus, and completely controlled by cortical areas by the swallowing centers in the brainstem. and the communication with the brain towards the muscle and several cranial nerves, which is most important, trigeminal, which is a 5th cranial nerve, and facial nerve, 7th cranial nerve, and glossopharyngeal, 9th cranial nerve, whereas vagus nerve also 10th cranial nerve. Similarly, accessory 11th cranial nerve. These 5 cranial nerves plays a major role in the supplying of the nerve role and nerve action to the swallowing mechanism. So thank you. Hope I made you to explain the clear mechanism of swallowing. First of all, you all again excuse because I couldn't able to prepare my PPT presentation because of my laptop service under service.
Sir,
Hello?
thank you very much, sir.
Hope I made it clear. Hope everyone understood. I want to ask everyone.
Sir, one thing you can do similar way. Now you are able to visible in 1 or 2 minutes. Explain the gist of your topic so that everyone will have a conclusion of your topic.
Means, as I said, from oral cavity to stomach, the process of swallowing, okay, happens from oral cavity to stomach. But medium is pharynx and esophagus. So this entire process needs, okay, as I said, total organs involvement and muscle involvement and neuromuscular coordination and cranial nerve involvement and the cranial nerve centers at the brainstem level. So all these together has to work, then proper swallowing mechanism establishes. So that's why whenever mainly swallowing difficulty, maximum we found in neurological disorders only. If neurological condition is good, so maximum swallowing easily treatable. If neurological condition is there, then it will be difficult. We have to examine in different modes and methodologies. Then we have to plan accordingly.
Wow, very nice,
And
sir.
one more very important point I just forgot, because the patient we have to tell completely at 45 degrees sitting recline position only helps for the easy swallowing. Okay, 45 degrees sitting recline position. Many studies showed, mainly especially video fluoroscopy studies, okay, maximum times it has given at the 45 degrees sitting recline position. Everyone should remember this point. Thank you.
Wow. Very nice, sir. Sir, can you tell the physiology? Hello, sir. Are you able to hear, sir?
Yeah.
See, physiological point of view, what considerations a speech language pathologist should be careful? Like physiology is for two. One is primary, another one is secondary function, that is speech.
Yeah.
So primary function and secondary. So when we go across certain, maybe there are certain things which we should not trigger.
Okay.
Anything like that in swallowing or
swallowing, when it is coming to the physiological or clinical aspect, we should not give water. We have to start with the solid, that too especially semi-solid. Okay, and keep asking the patient, means chewing condition we have to examine. They have to masticate it properly. Without proper mastication, that is a primary role of our ASLPs, our SLPs, so that we have to sit in front of the patient, ask them to keep chewing more than swallowing, because it's under the voluntary control. If chewing is proper, automatically neuromuscular coordination will happen. So ease reflex will develop. In that way, tongue also won't be in that position in hurry to push the food to the pharynx. So tongue will be under control. Slowly food, whatever the bolus formed, slowly it will get pushed to the pharynx and automatically esophageal sphincter will open. In that way, choking aspect will come down. That is a major important role of our SLPs. Okay, we should not make rush to the patient. We have to take, for example, simple piece of biscuit also you have to give minimum 6 minutes of time. Okay. Let them chew properly. Okay, whatever the chewing mechanism develops, it facilitates easily for the swallowing mechanism.
Very nice, sir. Sir, one more, this one, a question from my side.
Yeah.
How saliva helps in this physiology?
Very important. Maximum, because anytime saliva, okay, we know saliva got lot of enzymes actually. So first phase of digestion occurs in the mouth only. Okay, very important. Saliva mixes with the solid food and it becomes smooth. So easy way to push to the pharynx. So tongue won't, okay, comes under the stress position. So for the tongue action will be smoother. If the saliva part is good, saliva secretion is there, or we are facilitating to secrete the saliva inside the mouth. So obviously the food process of swallowing mechanism will be smoother and smoother. Very good question it is.
Right. Thank you, sir. One more very important aspect. When the choking is, when the choking is occurred, means suddenly it occurs. Means with or without knowledge of SLP, proper handling of SLP, choking may occur. At that time, at that moment, what kind of measures one has to take?
Excellent, excellent. This is the brilliant question, I can say. They have to push the patient from the backside. So they will move front, move ahead. So automatically with that pressure, voluntary mechanism, okay, mouth, our mandible gets, maxilla and mandible gets open. Means mouth cavity will get open and food immediately will come out. Okay, that is a 45-degree angle. If we are bending backside, 135-degree angle, and automatically food will go inside and choking will, okay, it will be under a dangerous situation. So we have to push head towards the front side. So obviously 90 to 45 degrees patient will come and food automatically, involuntarily it will come outside. Reflex, that is what reflex action.
Sir, sir, one more question. When we go with the bedside treatment as well as when we go with the common treatment, casual. So I am not aware of this bedside treatment exactly.
Okay.
Is it angle which makes difference in treatment process or any other aspect which is important?
Reclining bed we have to use. Okay, bedside aphasia patients with, okay, following dysphagia, swallowing difficulty. Obviously, maximum time we see right side hemiplegia means compulsory swallowing difficulty will be there, initial stages. Okay, based on the severity of stroke, again, dysphagia depends. Severity of dysphagia depends. So reclining bed means first we have to make it straight. Means always bed will be under 180 degree. From there, we have to make it 90 degree. At that time, we have to put our hand on their head, we have to move little front. So automatically 60 degree to 45 degree, then we have to feed them. Okay, initially while in the nasogastric tube only, we have to target the oral feeding. Okay, because we should not remove, once the patient starts the oral feeding means we should not remove because tablet, medication, so many things are there. Till that time, we have to keep the nasogastric tube when till the time they are very confident with liquid swallow. If once water and the liquids they are okay taking with their hand, easily we can remove the nasogastric tube.
Very nice, sir. One more enthusiastic question.
Yeah.
Sorry, I'm not.
No. Because it may help many participants.
Yes.
Okay.
Yes, sir.
Please.
Sir, one more thing, like when it is in children and when it is in adults.
Okay.
Children anatomically and their
narrowing structure.
Their structure is different
dimension,
comparing to adult. So which cases and what kind of considerations like measures need to be taken for both?
Okay. So as we know, already anatomy itself is concised, very narrow structures, very precise structures in the children. So bolus formation itself, okay, whatever the bolus formation, little bit quantity of food we have to give for the child, for example, 1 teaspoon, whereas for adults, 1 tablespoon. That is the major, okay, difference.
Sir, and one more, as you are an expert of autism also, like autism spectrum disorders.
Yeah.
And this question is regarding the special children with following difficulties. In which cases we see this kind of following difficulties and what kind of treatment approach we have to.
Yeah. First, we have to understand already in autism and other conditions, neurological conditions, hyposenses will be there. They can't sense how, if we put the food, no, the reflex action is so immediate, so quick, automatically they will try to swallow it rather than chewing anything. So we have to work on properly vegetative skills. So vegetative skills, it will in turn facilitate for chewing, proper mastication, and slow swallowing, all these, and blowing, okay, blowing, sucking, all these aspects we have to work in on the children, especially because of hyposenses. They can't even sense how much food, what kind of food we have kept in the mouth. Immediately they will try to swallow it without chewing properly. When it is coming to the cerebral palsy, multiple sclerosis, and even at times the Down syndrome, even cleft palate, okay, it will reach to the nasal cavity also in cleft palate situation. But soft palate is the main organ which really suppresses not to reach to the nasal cavity.
Sir.
Okay, that is very towards the nasopharynx level also. That is the soft palate. So the proper vegetative skill development only helps for the proper swallowing in children. For adults, it's no need actually. For adults, only the mechanism we can develop, we can show, they will slowly try to understand. Whereas autistic kids, they never, because of their thought process, very primitive thought process, very lack of attention, they can't observe properly. So each and everything we have to do for them.
Sir, there is a concept of somatosensory.
Yeah, somatosensory mechanism.
Can you highlight on that, sir?
Somatosensory, we need particularly, we have to examine thoroughly buccal cavity, oral cavity, cheeks, how much sensory level, how much hypersenses they have got, how much hyposenses. Based on that, means again it depends on the individual to individual. Okay, that's why it is a practical based actually. So after examining the patient only, we can establish somatosensory mechanism. It's not that whatever the somatosensory mechanism I'm telling, it is a generalized for every kid. That is what. So it will be easy if I am with the patient, then it is a very easy for me to show everyone what is exactly somatosensory mechanism. That is
actually,
okay. But you got no somato, is it body? Sensory, body is a mechanism. Their muscle is there, the nerve supply is there. Okay, we are whatever the routing of nerve supply to the body, there we are going, and there we are developing the mechanism which is giving the sense to the cranium, brain. So that brain centers will be active. Same way, the brain will send the reflex to the body. That is so-called exactly somatosensory mechanism.
Very nice, sir. Very nice, sir.
Because again, it differs from the individual to individual. So
yes,
explaining is very easy. But to establish the particular somatosensory mechanism to each individual is a very difficult task.
Yes, sir. Yes, sir. We are really pleasure to have this kind of practical discussion where the issues are there in special children as well as the adults who come across with variety of disorders or diseases such as dysarthria or aphasia or some other which is connected to dysphagia. Sir, thank you very much for explaining.
Thank you, Professor Dr. RKP. Excellent questions you have asked. I think many of us got benefit with this discussion. Firstly, I want to thank you, and even our Honorable EC member, Dr. KV, very well he has presented. Now we'll welcome our Dr. Gangaraju, one more Honorable EC member. Please welcome.
Yes, sir. Now it's time for our Honorable EC member who is recently elected in TASLPA in body. Now I request him to start his lecture. And coming to Dr. Gangaraju, he has done PASLB from the Swikar institution, and he has also completed diploma in swallowing disorders, that is deglutology. So he is popularly known as deglutologist and
hello sir, excuse me.
Yeah, who is this?
Sir, I am Venu, sir. Venu.
Yes, Venu.
Sir, I have one question to Premna, sir. Can I ask? Sir?
Can you ask end of the session, sir? Are you
Yeah.
available? Premnath, sir?
It will be discussed in the session, discussion session.
Yeah, we have.
Oh, okay, sir.
discussion
Okay,
session.
okay. Okay, then I'll
End
ask.
of the presentation, we have discussion session where you can pose your questions. Okay, so the coming to Dr. Gangaraju, who has done his diploma in swallowing disorder and who has also done MBA in hospital and healthcare management, who is renownedly known as a deglutologist and SLP, who is currently working in KIMS Hospital, that is Krishna Institute of Medical Sciences, Secunderabad. Now I welcome Dr. Gangaraju to please start his presentation. So I want to share the screen. Is my screen audio visible?
No. Kindly unmute all the people, sir. Redmi one is getting disturbance here.
I don't have that. I will try from other system. 1 minute.
Sir, you can mute everyone, sir. Kinda ఉంటుంది చూడండి, please.
Yes, yes. I will do that. I will do that. Can you please, Dr. Nagendra?
Sir, actually, you are the host, no? Please make me a host again. I will do that.
Okay, this is like you have made mobile as a
And you got switched in both the mobiles, sir. It's resounds now. Now we are getting resound, sir.
Yeah. Are you able to see?
Still, you are the host, sir. Actually. Sir, Rajinder, sir, any technical problem?
Yeah, just a minute.
Meanwhile, we'll welcome Dr. K. Venkatnarayana to present pediatric cases.
Doctor, no, none of the days, no.
Sir, can I present?
Yeah, start presenting because people are leaving.
Yeah, that's what I'm saying. Can I present? Make me host. I'll present it. Dr. Rajendra sir, make me host. I'll do it. I may present myself. Sir Rajendra sir, make me host. I'll present. Dr. Narendra, can I present now? People are leaving.
Go on, Venkat. We can hear you. Go on.
No, they have to give me a host.
Okay, okay.
Give me one.
Mohan Reddy, can you unmute, please?
Power process. Literally 2 hours.
Meanwhile, I request.
Kindly make me host. I'll present.
Dr. KV, you are host now. Actually, there was some technical error from Rajendra's side. It is cleared now. Please continue.
Okay. Hello, welcome back again. Till now, from my presentation, we have seen the structural anatomical differences between the children and the adults. So now I am going to present, and especially on the how the children or how the neonates like going to be treated, and how the treatment process and how they'll get benefited and all. So here I want to show one case. The first case is like this. One second. So this is the one case where I was treating recently last month. This is the case. Just observe the picture, observe the video, how the kids performance, how the kid is reacting to this. This is the first day of assessment. You can see it here. See, his heartbeat rating is very high. He's taking very short breaths. His sound from the mouth is saying some different type of sound. So he's that time he was around 25 days. He has got seizures. He was admitted to NICU. There is a lack of taking milk from mother, and was not able to swallow something properly. Then I have approached this case to check out. So this is the first day. Just observe his rib cage movement and his hand movements and all, so that he can follow them. See, short breaths. To come into second breath is during during giving our rehabilitation, swallowing, exercise, treating and all. I am here, observe this carefully, this video, how the reflexes are getting from the child when I'm treating. Observe his hand movements whenever he's getting gag reflexes and all. However, I'll explain again. Just watch it. Here I'm encouraging the child's stimulating the child's pharyngeal wall, buccal cavity, and getting stimulated so that they'll get the reflexes to the swallowing to get the swallowing better. Observe his hand movement. Suddenly push my hand. See, he's suckling that one. See, you can see his hand. He was pushing my hand aside. That is involuntary reflexes, but he's doing very well. That is working on the gag reflexes. Slow movements from lip to insert, from through the buccal cavity to the esophageal wall. Walking and the gap reflexes movement to be initiated. That's good boy. Pressing the tongue down so that he can move it up. See, his suckling movement started, the lips movement is started, lip sealing is initiated. See, tongue out. This video is around after 12 to 13 sessions, after 12, 13 sessions. So this is the one video. The first one is during assessment, second one is during the therapy after 8 to 13 days. And this is a final video. You can observe here how he is taking milk through the nipple and how fast he is taking, and observe his buccal movements, jaw movements, breathing capacity, volume. You can just observe it, how fast he is taking and
अटेंडेंस बनाना एक बार भी किसी को नहीं आएगा, हम लोग अटेंडेंस बहुत कॉम्प्लिकेटेड अटेंडेंस बनता है। इसका क्या सीएल है,
without giving any time gap also he is taking very much. He is maintaining his breath control, maintaining his respiratory control. See, continuously her mother is giving continuous milk without giving any gap. Also he was able to swallow it properly. His muscles got strengthened. His respiratory system, respiratory working well, taking breath very well. So there is no chokes, no aspirations in this video. You can see. Parents are very happy. They felt very happy, tear in their eyes. Actually, this baby's father is CAF nearby area in Gachibowli. So that is the one case. Very happy to share that case with you. Is just around, now he might be around 60 or 65 days. I'll be very happy to this case and all.
साउंड का मोर समझ लियो क्या?
नहीं, वो इस गेट से निकल के ना उस गेट में निकलना।
Mute your
Now my second case is here. This is one of the case. I can't say any mute here. I request everyone to mute their mics, please. Now this is one of the video. The second case. This boy is around 3.5 to 4 years of age. This case is just as in this last month only again. This boy is of history of meningitis, severe meningitis. Due to which he was admitted in the hospital, and proper care taken was not taken by the doctors, also even by parents also. That is the reason he has got with the bed sores on the backside. bed sores. So he was very irritating. He was not cooperating at all. Observe this video carefully. He was not at all cooperating with us. But still, we made him to do exercise and all. This is during rehabilitation of swallowing. Yes. Here I'm doing the digital manipulation techniques of larynx, slowly giving exercise movement so that he can able to stimulate his oral structural movements properly.
Hello, sir. Sorry for the interruption, but someone's microphone is on. We're not able to hear your voice, sir.
I request everyone to make more on mute.
Dr. KV sir, you are the host.
Dr. KV, please go to the participants and go down. You can mute everyone. You can see that option. Mute everyone.
Yes, yes. Thank you. So this is the video we can see. And the next one video is after treatment, after therapy. I'll show you the other video. Be 1 second. So this is the video after the treatment. Just observe it. You can observe his movements of larynx, his jaw movement, lip closing and all. See. Now they're trying with the liquids. So this is how the two patients of mine was in the case presentations, this infants, neonate infants. So I'm happy to present these cases here. That's all from my side. Any queries we'll discuss during the discussion period. I'm happy to share these videos on this swallowing awareness March 16. Thank you. Now, Dr. Nagendra is a host. Kindly take the sessions forward. Dr. Nagendra.
Hello, sir. Professor RKP sir, Gangaraju is ready, sir. Dr. Gangaraju.
Unmute your mic, sir.
Yeah. Okay. Am I audible now? Hello. Hello. Hello.
Yes, sir.
Am I audible? Dr. KV.
You are audible.
Your voice
Sir,
is
Gangaraju
breaking.
is ready. Rajendra sir.
Rajan sir.
Hello, sir. హలో డాక్టర్ గంగా ఎక్కడున్నావమ్మా మళ్ళీ స్టార్ట్ చేయి పువ్వనో ఉలుకులేదు నేను మాట్లాడుతున్నా చూడు యా హలో సార్
Can we ask some questions to Venkat Narayana sir?
Yeah, who is the person asking questions? I can answer in the meanwhile. So I have seen. Yes, was a question?
Sir, what is the second client PD, sir? What is the main difficulties in swallowing? Actually, that video is completely mute. We are unable to hear what happening over there. We can see you are assessing with giving food and you are giving liquids. You are assessing in his jaw movements, but exactly we didn't understand what is his problem.
So the thing is, the kid was when he was the second case or first case. The small kid.
Second one.
That's okay. The kid was, he was first got high fever. Then later it was shifted to brain meningitis. Due to meningitis, the kid was totally, went into unconscious mode. The parents were shifted the kid to the hospital. In the hospital, they have, gone different types of perform test, and they find out that it is a nephrotic syndrome. Nephrotic syndrome is that indicates of the more comorbidities of with swallowing issues and the reflexes in the mouth and the information that passing to the brain to the oral structures got affected. And due to that reasons, his breathing was got affected. So that is when they put the Riles tube and they put the baby on the ICU and ventilator for a few days. After that, because of proper intake care of proper not care taken by the parents or the doctors, due to which they have got bed sores on the backside. The pictures are there. I'll share you sometime. Due to that also, like the kid was not in good position to take rehabilitation or swallowing therapy from us. Then later we called. We asked the parents to come to clinic. We have given proper treatment for that. The bed sores first. Then worked on the exercises, needs different types of exercises that we do generally for the swallowing kids. Worked on the lip seal exercises, worked on the gag reflexes, buccal cavity, and then slowly the digital management technique for these laryngeal movements, worked on the breathing capacity to control the breathing while swallowing, while deglutition. So these are exercises we did, and main thing is he was affected mostly with this meningitis. The main complaint is meningitis. Then later it was pointed out that is a nephrotic syndrome.
Okay, sir. But what about second case, sir? First case we are understood, but what about second case?
A small kid, right? The small.
Your second video, sir. Second case study.
What I was discussed right now is the second video.
One boy is sitting with her mother, with his mother, right?
That is the case. Is a meningitis with a nephrotic syndrome.
Okay. Okay. Thank you.
Yeah. Okay, ma. Okay.
Hello, sir.
Yes.
You showed the neonatal 25 days baby.
Yes.
What was the complaint of swallowing, sir, initially?
See,
why they
baby,
approached to you?
Yes.
Neonate.
Yes. The baby was admitted in ICU because of some medical reasons. First thing is he is in a premature delivery. Like it's around 2.45 kgs. Then later, because of some medical comorbidities, and was shifted to NICU, admitted in that. And after 5 to 6 days, they called me up for the assessment of the swallowing and feeding. Then I have seen while swallowing and all, I have given some drop of milk. I have seen that his muscles getting very fatty. As soon as the milk is getting into the mouth, he is sucking for first time. The second time, whenever you are giving a milk and all, the muscles are getting fatting, and the milk was like pooling at the glottis area, epiglottis area. So due to which is taking more breathing patterns, more short breaths of breathing, and he was not able to control his the BP was shooting up, heartbeat was getting up. So the doctors was said to approach me. So I did the same exercise and all. After seeing that, and he also got affected with the seizures, due to which his muscles and his body was very weak and not able to swallow, not able to suckle the nipple of mother. The different conditions we have seen. So after discharge from the NICU, they came to my clinic. So then I started treating at my clinic for first 13 days. After 13 days, the second video I have seen, after 13 days, I was started working on the gag reflexes movements of the pharyngeal wall. Then the buccal cavity sensory issues, working on that. Then later worked on the lip seal, and later worked on the manipulation techniques of larynx. Then breathing holding capacity. There are certain capacity we work, generally we work, right? So that capacity works, and this jaw movement and all tongue movements. Slowly he was getting to track after a few days, around 20-25 sessions of giving a rehabilitation of the therapy and all. He is into track. Then later, slowly, I have given feeding at my clinic under the presence of monitor. This is the first thing you need to observe is monitor plays a major role in giving feeding to the kids, infants, neonates. Because as I given in slides, especially 140 ppm and 132/44, like the blood pressure, and this plays a very major role that we need to observe keenly. Then slowly, based on that observations, if that's getting stable, then we need to increase the feeding to the kid. So that was done after 30 to 40, 30, 35 sessions. The kid was able to take the milk properly. You have seen the video that mother is giving milk to the kid. That is in a proper inclined position and all. He was taking the milk and all. Parents are happy. I am happy.
Till that, the baby took the feed, sir?
This was a Ral's tube, right? There will be a Ral's tube through the mouth.
Okay.
Yeah, the Ral's tube. They have given some vitamin related, mineral related, possible like that. They have given something like that.
Okay. Thank you.
Yeah.
Hello.
Hello. Hello.
Sir, Rajendra sir, please start.
Are you
Sir. Your voice is not clear, sir. Still the same problem.
Now I welcome our Gangara and ASP. Are you able to see?
We can able to see the slides, sir. Voice is not clear.
Hello, good afternoon, everyone. Myself, Dr. Gangaraju, working as a rheumatologist and speech language pathologist and audiologist in this hospital. Now, today, I'm feeling very happy to share my knowledge through the TASLPA webinars in the occasion of World Swallowing Day. So, as of now, our dignitaries are talked about the swallowing and in many aspects, and anatomical aspects as well as physiological aspects, and when coming to the clinical aspects. Now, here we need to discuss about the swallowing difficulties, how the patient is facing actual symptoms and the challenges of the management. So, what I tell with the previous cases, among those cases, now I am going to be present one case here. The presentation content maybe the problem is stuffing sensation, food stuffing sensation, and as well as the pure pharyngeal dysphagia. So here, one of the case we can discuss about the types of dysphasias and stages of dysphasias and what are the symptoms of or diagnoses already discussed about. Hence, even though I want to tell you in a rapid manner, so dysphagia is considered as a movement disorder. Okay, we can consider as a movement disorder. It can be there are various types of swallowing disorders such as like pre-preparatory stage, oral preparatory stage, and the pharyngeal stage, and esophageal stage. Here, as a speech language pathologist, we can consider as the pre-preparatory stages and as well as oral stages and pharyngeal stages. We can deal with these kind of dysphasias, and the esophageal stage or gastroenterologists and other medical professionals, they can deal with the esophageal stage. Whereas come to our up to that pharyngeal stages of swallowing, we can deal. We are the right person to treat and evaluation that swallowing difficulties. So now, what are the brief symptoms in the swallowing patients? So we can swallowing disorder is a not direct problem, but it is a since as a symptom of neurological conditions such as an organic conditions like oral cancers and as well as laryngeal cancers, head and neck cancers, and those things we can consider. Hence, it is more contributing factors on human health. So Here, we are going to be discuss how to do assessment and care, how to handle the patient, how to take care of the patient, what are the tests we can do for the patient with dysphagia. So, medical services and what are the tests is required and when to we see the patient, when not to we see the patient, and uh, and how to prepare the patient, those and what are the tests required. These are the minimum. How what are the minimum information need? Those we need to discuss. And the management of this one, and finally we will go to the assessment. We have to treatment. We need to set the treatment plan, and after assessment, we need to set the treatment plan as a and what are the need to be counseling, what are the importance of the counseling, what are the realistic expectations of the patient, outcomes of the patient, and prognostic factors of the prognostic factors. We need to discuss about the prognostic factors, and as the lacunas also we need to discuss with the patient attenders, and as well the measures to be, what are the measures to be taken by the speech language pathologist during the therapy courses, and what are the active speech and swallowing therapies we need to follow. Now, on the what is the swallowing management, what we did the swallowing management in the what are the techniques we discussed in the what are the techniques we are used in the process of the management of swallowing. So here are the some we mentioned here. So now I'm going to be present two cases. Among that, we now the first case is case name is 007 and date is 9/3/2023. Um, age is age is 55 years and gender is female. Sorry, here is the by mistake it came as a male. So the time is time was 8:55 p.m. The case history: the patient came with a complaint of altered behavior. Patient came to ER with a complaint of altered behaviors since today's morning, and patient was apparently asymptomatic till yesterday 10 p.m. The morning onwards, no speech, no speech. The patient doesn't have any speech, but only responding for the commands. However, the repetitions were observed. Complaint of swallowing and swallowing difficulty was observed, and other medical history. The patient suffering with type 2 diabetes and hypertension since last 2 years, and the medication for the same. And general observation was done by the ER people as a BP is 150 by 100 mmg, and pulse rate was at the time of the ER 101 per minute, and respiration rate was 19 cycle per minute, and saturation levels was SPV saturation levels is 98%, temperature was 98.6 Fahrenheit. So at the time of the year, the investigation was done MRI brain and Doppler, carotid Doppler as ABZ, and PT with INR, CBP, RFT, and this test was done by the ER people. After that MRI, it was revealed as a right MCA infarct with a right MCA occlusion. So they were the patient is directly admitted in the wards. So why? Because of the patient, they are recommended to admit in the emergency in ICU, but the patient attenders and patient is scared about the ICU environment. That's why they were admitted in wards. And at the time of wards, that is this is the 10/3/2025. It happened. The medical treatment was administered by the neurologist and medical team. So the first medication tab ecosprin 150 mg OD, and the clopitab 75 mg OD, Atravas 80 mg BD, and neutrophil 1200 mg BD, and Fanta 40 mg OD, and insulin according to GRBS scale, thyronam 75 mg OD, and speech therapy and physiotherapy. they were advised as a treatment process. So, and the 10th day, they were seek the speech language pathologist consultation for the evaluation of the swallowing. Okay. Now, as a speech language pathologist, uh, as a speech language pathologist, my interventions and my assessments are replaced majorly as they said. So patient is still she is awake but altered behavior, and she was under stress and as well as anxiety. So that the patient is and that on that situation I am really more enthusiastic. Why? Because of I'll tell you the later. Now, as a speech language pathologist, I went to the ward and see the seen the case sheet thoroughly, and I observed a lot of things and BP, pulse rate, as well as our vitals, and as well as a hemodynamical status, everything was observed. Then I went to the bedside and I took a call to nurse to arrange the everything such as the instrumentation like tongue depressor, glove, torchlight, stethoscope, and suction. These are the things instrumentalized by the staff nurse. So, as a speech language pathologist, just I took the pre-preparatory stage and to assessment first I observed the patient status, how the patient feels the sensorium, how the patient's sensorium, and how the command obeying system and all what are the present hemodynamical status of the patient. So after that, I enter into the oroperipheral mechanism examination. So it appears drooling. Why? Because of the patient has left facial palsy, partial facial palsy, no lips, no adequate lip seal, tongue partially deviation towards right side. So I observed in that the appearance in the oral system, oroperipheral mechanisms appearance. So after that, I observed the functions of the oroperipheral mechanism. So range of movement and the tongue propulsion and tongue based propulsion, as well as this palatal anatomical and functions system, and the range. So when I observed range of movement and all the functions of the oral cavity, it looks range of motion is normal, and as well as bilateral gag reflex, right and left gag reflexes was normal with adequate strength, and bilateral vocal cord are normal, and higher laryngeal elevation is adequate at the time of the evaluation. So bilateral vocal cord are normal, and this was the assessment by the voice quality assessment was done, and bedside voice quality assessment done. Through that, we came to the know the bilateral vocal cords are normal, and higher laryngeal elevation is the most important factor. It is an instrumentalized to as it will work as an aid to travel the food and in a proper course. And voice analysis was done. It was normal. So endoscopic evaluation was done. Everything endoscopic evaluation it reveals normal. And the last final, I did that bedside swallowing evaluation done. So in that bedside swallowing evaluation, it's a plays a major role in this case, especially so food sucking sensation, complaining the patient among. So here, the bedside evaluation, we are used to that liquids as well as semi-solids. We use it as a aids, and as well as here. And while we are going to be initiate bedside swallowing evaluation, we thoroughly counsel the patient. Don't be hesitate and don't be stressed and don't hyperactive. I counseled the patient, and after that I initiated clear liquids, and she took. But she's complaining. So, sir, food is stuck my throat, sir. I'm not able to swallow. It is a little irritation is there, sir. I'm not able to swallow. The water is there, so that's what I'm not able to swallow, sir. She is complaining. But after that, after liquids administration, we initiated this semi-solid diet. So she's took semi-solid diet also with the effort. She also felt with the stacking sensation with both the both type of foods, but she's revealed more discomfort with the liquids. It's more with the discomfort with the liquids, and that's she said, sir, I'm feeling more difficult liquids. Those are in my throat only, sir. It's not went in my stomach. She said. I laughed it. Why? Because of I thought nothing is there, but she's complaining the still food is there. That's what I laughed, and I said the same thing to. I conveyed my thoughts. What I thought it, and uh, and after that, I came to the thoroughly based on the previous history as well as endoscopic diagnosis as well as the patient hemodynamical status, and as per our SLP's diagnosis, I came to know that there is a problem in throat. Like this is we can call it as a globus sucking sensation. We can I diagnosed as it is a sensory dysphagia or globus dysphagia. Why? Because of we can say that it is a sensory or globus sensation means when there is no problem or no pain while swallowing, but it is there is abnormal sensation in the throat. That's what we are calling as a sensory and or globus dysphagia. So here it is that there is this globus sensation or stacking sensation. There are the causing three types of physiological aspect. One is anatomical one thing, and physiological one thing, and psychogenic. Here in the neuro cases, mainly I saw the so many cases. The only psychogenic factors only with this. The causes of psychogenic stacking sensation is mainly stress or behavior alterations as well as GERD. That is causing for muscle spasm. So it creating the stacking sensation. That's what the patient felt stacking sensation. See, in that case, there's a management. What I followed in that case. First, I went to the thoroughly by I did the counseling. After that, I used relaxation techniques and desensitization. Within the desensitization program, we are using the many therapeutic exercises such as oromotor exercises, cardiac resonance, thermal stimulation. I used that. So while the therapeutic counseling is most important, so we can see the patient is there is no anatomical and physiological abnormalities we find, but but the patient felt there is something. This is causing more aggravated patient. So that we need to make the patient to understand the problem. What is there and what not is there. What are the difficulties will there and what not there. So we need to thoroughly explain by doing the effective counseling as well as by using the relaxation techniques. What is the mean by relaxation? Here I want to There are so many studies are showing that relaxation means we, as a speech language pathologist, we can see that always relaxation means, please sit properly and take a deep breath and release your air through the mouth. These kind of techniques we can use. But whereas comes to real practical scenario in relaxation means we need to explain the condition what is there in simple language, in simple their language and their terminologies, and make them to confident. So what if the patient know or patient attendants know the what actual scenarios, then the patient will get the relaxation and he's ready to swallow, and he's or she's ready to take the food and those things. And where the next treatment option is desensitization. In the desensitization, so in this desensitization treatment technique, we used to modify how sensitive an area is to particular stimuli. This technique is to utilize to decrease or normalize the body's response to particular sensation by using the different treatment tools. So that we can desensitize the actual what the patient felt that behavior. So desensitization we can do it, and that's therapeutic. After that, oromotor exercises as a part of the desensitization. So just tongue stretchings as well as tongue based stretchings as well as uvula stretchings as well as vocal hummings, vocal warm-up exercises. These can create cul-de-sac resonance and thermal stimulation. How the cul-de-sac resonance are utilized for this to overcome this stucking sensation. And the cul-de-sac means the any closed setup we can utilize biovocal acoustic spectrum, which helps to desensitize that particular symptom, so that after that the patient will swallow easily. Now another case. Here the case 002 001 is 6 and case is maintained. They came to ER with a alter behavior since today evening and balancing problems, severe cough, not able to swallow. And as a language pathologist, speech language pathologist, what is we found in this case, and the oral peripheral examination done. The appearance, soft palate edema is noted, fine, and velar deviation also we found, sorry, hypersalivation observed, and poor pharyngeal tone was observed, and functions of poor pharyngeal tone, bilateral gag reflex absent, and poor breathing pattern observed, and poor voice quality, that is breathy voice, and left vocal paralysis also we observed. And as a word, provisional diagnosis is the pharyngeal dysphagia with breathy voice, with left vocal paralysis, with the lateral medullary syndrome. So, as a speech language pathologist, I administered first whichever may be the case. So the counseling part plays a major role before we are going to be the treatment. Why? Because of the suddenly if we did some procedures, the patient may get stressed, scared. So that we need to go for counseling for the initially we are going to be the treat the patients. So here in general oromotor exercises to overcome the oropharyngeal spasm, and as well as vital stim swallowing therapy and voice therapy and cul-de-sac resonance therapies plays a major role. Things vital stim. And here what are the general exercises, tongue stressing exercises, as well as the Mueller exercises. Or as a speech language pathologist, very, very well. But here, vital stream swallowing therapy, this is the new technique. So in India, it is new technique, but in all other countries, they are using more advanced. So that's why here in vital stream swallowing therapy, they underwent for vital stream swallowing therapy for 45 days. So, and why simultaneously we practice oromotor exercises as well as voice therapy exercises and contact resonance vocal acoustic also we used for this. The outcome, what we observed in outcomes, see, vital stream with swallowing general oromotor exercises and voice therapy with it combined these we found more effective, but only single vital stream swallowing therapy is not worth it. So conclusion here, I want to conclude that the case with the dysphagia always a task for the speech language pathologists. However, the case with the sensory dysphagia requires more attention as it is misleading with most of the normal clinical features. The SLP has to do comprehensive evaluation to rule out the pathology and initiate the therapeutic management, particularly in this peculiar cases of sensory dysphagia, and patient counseling and their relaxation and the realization is the most important, along with oromotor exercises and Cul-de-sac resonance and thermal stimulation accordingly. The pharyngeal dysphagia with the lateral medullary syndrome is associated with voice problems. The vital stream swallowing management plays a key role along with oral and voice therapy techniques for the management of voice. Now we will go for videos. And also here I want to mention that before we are going, if the patient is complaining throat sucking sensation, before we are going to be initiate, we must rule out whether is there any organic problems such as like pharynx cancer as well as head and neck cancer. And we need to thoroughly evaluate. Then only we need to initiate our treatment. So, meanwhile, please, if any questions, please. Is there any question? Is there any questions?
Sir, I have dropped a question in the chat box, sir, because my voice is not very well.
So, yeah. Sir, I'm not hear you, so your voice is. Can you ask again?
Sir, I drafted the question in the chat box, sir, because my voice is not well today. Please.
Okay.
Dr. Ganga, the question is, a child who does not latch will have speech delays issues. Number one. Number two, a child who uses different intonation for we calling T can be corrected. Is it a neuro issue or anything else? For example, for Johnny Johnny yes Papa, child singing Tanny Tanny yes Papa. Just open the chat box, you can see.
Yeah. Just I'm seeing that. So what is the age of child?
Sir, 5.5.
5.5. Okay. What are the other comorbidities?
Mild autistic, sir.
So it might be articulation. It's not related to neurological, but there is some oromotor placement as well as somatosensory issues. Due to that, the patient might be.
Can I answer this question?
Yeah, please.
So the first one is latches is there will be definitely a problem with the speech related speech and speech language development issues because of poor coordination of the information, because however you said it's the autism case, the neural connections formation, if he more exposed to gadgets, here two questions will be answered at a time. So the thing is latches have definitely high speech delays. And second question is, the problem is you said Johnny Johnny can be sometimes says in other way. 1 second.
Yes, sir.
I'll find out the question where it is. Johnny Johnny sing as Papa, and you are saying Tanny Tanny. Yes, Papa, right? So the thing is, the processing of the auditory system is in the right way or not, we have to check it out that. Because the understanding of the sound plays a major role in expressing of the sound, like output of the expression. If he is hearing normally a Johnny Johnny, but he is expressing out in Tanny Tanny, means check out for the placement and articulation of the tongue movements.
Okay, sir.
The second way thinking is, if he was saying the same thing, Johnny Johnny Tanny Tanny means the processing in the brain, he might be listening listening as a Tanny Tanny. That might also got affected. If hearing is normal, then go for check for placement and articulation. If hearing is get affected, check for the hearing, because these two plays a major role. And one more thing, if the child exposed to his gadget at the screen time, the voice that gadgets, for example, some people will say, some kids will, yeah, no, yes, Johnny, Johnny, yes. This type of voice we can observe with the autism kids. Why? Because as you know that there is a critical period of time, the developmental structural growth of the brain and maturation thinking process of the brain, neural connections of the brain will grows at this age, 1.5 to 2 years, this grows age. What are the sounds we hear? What are the sound the kid hear? What are the things that he observed? The same intonation pattern will be expressed out by the child. Here means the child wantedly not doing anything. Whatever the brain has, he is expressing that.
Okay, sir. Okay. Sir, the BERA test is done. BERA is cleared. Or
see, BERA test is done. BERA is normal. That's good. Then check it out for the placement of articulations.
okay, sir. Can it be corrected, sir?
Yeah, it can be corrected. No worries. It can be corrected.
Right, sir. Thank you so much. Very kind of you.
Excuse me, to add on to that, may I add on?
Yes,
Hello?
Jyoti.
Yeah, hi. This is Jyotilal from Rainbow Hospital. To add on to your answer, sir, what is the age range of child first?
5.5, sir.
5.5.
So 5.5, right, with mild autism. And yeah, if the child is able to do his daily work and is able to communicate, okay, with basic lifestyle and all, then there is a definitely chance of misarticulation rather than other aspect.
Yes,
And
yes.
being a language delay, okay, being a language delay, I don't think any other aspect need to be looked out, because there is very less role of neurologist in this scenario. So it's all the audio speech therapist who deals with. Okay.
Okay, sir. Okay, sir. Thank you so much, sir.
Thank
Sir, very kind of you all to answer my questions, sir. Thank you so much. Means a lot.
With pleasure, with pleasure. We are happy to give answers with pleasure. Thank you.
And any there is a general examination. Are you able to see? Here it is, we can observe to assess the gag reflex, and it's a primary assessment for initiation. Technique and counseling as a competence here this this is exercise scoring evaluation is done with clear needs. So it's why we want to go for liquid assess clear of see we are create solid assess better solid assessment in the food process. So it is dangerous. Why? Because see in lungs most of the fluids are clear, in our lungs, okay, as well as oxygen. If we use any or whatever we use for we more dangerous than when compared to wood particles. This video is after management. Let's say we need to have and so that right side because the left side of the body so the skin are very less. That's what I have to do.
Hello. Yes. Now the session is open for discussion. If any few more questions, you can ask.
Hello. Yeah, I'm here, Arif. Can you able to hear me? Is it
Yes,
audible?
yes.
Yeah,
Yes,
yeah.
yes.
So wonderful presentations by all the panel speakers. I really congratulate them, and then also once again I wish them happy World Swallowing Awareness Day, and wonderful presentation by KV. And what is my question is, still now we have discussed about the forward flow of food, that is normal swallowing. Now because if you see, there is a reverse flow of food also happens, that is called gastroesophageal reflex. In so many patients, I think you would have seen. So if you have seen these kind of patients with this kind of problem, so what kind of treatment techniques you have used in your clinics? And do you recommend any kind of, have you recommended any kind of diet for them, specific diet for them? Please highlight on this.
Hello. Yeah, Dr. Arif.
Yeah. Hello, sir.
Yeah, can you hear me?
Yeah, I can hear you, sir.
Good
Wonderful.
question. Okay, GERD is the major problem actually. Gastroesophageal reflex disorder. Okay, nowadays, because of outside food, junk food, many of us developing the GERD. But the thing is, first part is majorly we have to refer to the medical gastroenterologist. Endoscopic mechanism, okay, is and a proper medication. Later, as usual, alkaline diet actually. The problem itself is showing that acidic reflex. To control it, okay, moreover, we have to provide them alkaline diet. Okay, even nowadays, many of us are taking a lesser water. Everyone knows per 20 kilos, 1 liter of water actually. If somebody having a 60 kilos, means compulsory 3 liters of water they have to consume. So if digestive process is proper, so obviously GERD problem automatically will subside. Okay, until unless they are keep having a mirchi bhaji, Mysore bonda, oil stuffed food, or chicken, roasted chicken, vagera, or spicy food. At that time, GERD problems reoccurrence continuously happen. At that time, okay, better to consult with the medical gastroenterologist.
Oh, thank you, sir.
Okay,
Thank you for
because
your
duodenal activity, intestinal activity, any ulceration formation, everything may happen secondary level. So
Right.
everything should be examined properly.
Okay.
Okay, when it is coming to the SLPs, so
yeah.
followed by diet, we have to explain how carefully they have to be, because many of the times they keep clearing their throat, voice, like that, regurgitation. Okay, that should not do continuously. Otherwise, the burning sensation will develop later. Okay, automatically hoarseness and voice related problems also, apart from swallowing problem.
Right.
Okay, spasm will develop over there. Okay, that is what.
Okay, sir. Thank you, sir.
Okay.
Thank you for your explanation.
Any more questions? Hello. Any more
Hello.
questions?
Hello.
Yes, audible.
Yeah, this is Isha from Mumbai. My question is to Dr. Gangaraju. See, I have a patient right now on board. She already had a Parkinson's since 2 years. Now it's been followed by a stroke, and she is having a dysphagia. And was on the PEG tube. Now the PEG tube has been removed, and she's on an RT feed. So I just want to ask, what should be the plan of action? Because since 2 years, she was also having a Parkinson's, and there is a lot of deviation in her oral movements.
Sir, can you repeat once again, madam?
I have a patient, okay, on board right now. Okay, she is 69 years old lady. She's already having a Parkinson's since 2 years.
Okay.
Now, 15 days back, she had a stroke. Okay. So for a few days, she was on a PEG tube. Now the PEG tube has been removed, and we have given her the RT feed, RT. Okay, so what should be my plan of action?
See, first of all, as you said, madam, so we, as a Parkinson's case, in that the rigidity might be there, as well as the secondary to followed by the stroke. Also, it's a big issue. So we can, as a speech language pathologist, first we need to assess the oropharyngeal mechanism, then we and the pharyngeal system. According to our assessment, we need to follow that. But probably, if it is any oral issues, first we need to mobilize that.
Yes, yes.
TMT.
Oral
Oral
movements
system.
are very much restricted. Deviations, lot of deviations are there.
That's what, madam. So for that, we need to use a few passive therapy techniques, which I was using in general cases. So by wearing the gloves and to insert the finger. So at the area of
Your voice
we
is
will
not
just
audible.
go to stress that muscle.
Okay.
Masseter muscles. So the patient little open the mouth, and after that, in that case, we closely insert that finger and we immobilize that. Just to make the massage like at the area of nasopalatine foramen, at the area of nasopalatine foramen. So that creates some itching sensation. The patient will automatically open that mouth little. So after that, we need to work on that TMG, temporomandibular joint. Why? Because of in these Parkinson's cases, temporomandibular locking is more. So the rigidity is more. That's what passively first we mobilize. Then after we acquire that whatever the mobilities we require. So then we'll follow the oromotor exercises, in general oromotor exercises.
All right. All right. Thank you so much.
Okay, ma'am. Thank you. And is there any questions?
Okay. Thank you all. Now,
I have one question to Gangaraju sir.
okay. Who is this? Can you introduce?
So myself Pooja.
Can you please introduce yourself?
Okay, myself Pooja. I'm from NIHS.
Who is this?
Myself Pooja. I'm from NIHS.
Okay.
Pooja.
Yeah, sir, can you refer any specific books for dysphagia?
Specific books for dysphagia.
Dysphagia, yeah.
Okay,
Treatment.
Dr. K.V. Narayana and Premnath sir. And
Yeah,
please,
we
sir,
have
answer.
some books with us.
So that it will be very useful for us.
Yes. So I can share the link to you regarding the swallowing books. We have some books, swallowing disorders, and by some other famous author. I'll share that, and dysphagia in children, dysphagia in adults. There is a book. I'll send it to you. I'll share the link with you so that you can go through that.
But particularly if you want that neurological cases, there is one book that's neurological swallowing disorders. If I have it, but I will share it with you. So if you leave your mail ID.
Please share your mail ID so that they can pass on to you.
Okay, thank you, sir.
The reference and possible PDF.
Yes.
Okay, sir. Thank you so much.
Is there any questions?
So I think now I have a question to Dr. Gangaraju. He is here right beside me. So what I want to ask is, when you have seen case 1 and case 2 presentations he has presented, so there is one term is known as sensory dysphagia. It is a very what we call misleading one. And how to identify such case, and what are the clinical features? Can you explain, sir?
Yes, sir. The proper knowledge about the swallowing is main important, and secondary to the whatever tools we are used for the swallowing evaluation, that is most important. So even though there is a endoscopic evaluation done, other medical examination was done, in that we didn't find any pathological changes. But here, where it comes to the bedside swallowing evaluation, we find there is a problem that is psychogenic. That's why we need to clearly observe, and we need to understand the patient complaint and other neurological and general medical things. Then only we come to know the actual diagnosis.
Okay. And what are the possible causes for such psychological, what we call, where the patient feels that he is having sucking in food? So, what are the possible causes? In which all cases we can see such things?
See, generally, all neurological patients often they are complaining. So, sir, my food is stucking in throat. I felt it is there is something in my throat. I felt food is stucking in my throat, and I seems to be something is there in my throat. This is a general complaint of all neurological conditions, and mainly in CVA cases, such as right and left, irrespective of their strokes. We can find these kind of problems.
Okay. Then there is a case too, which you have seen, that syndrome, right? Syndrome associated with dysphagia. Can you means what is that syndrome, and what are the accompanied comorbidities or the associated problems?
See, here, sir, we need to understand the MRI. It plays a major role. Why? Because of this is medullary syndrome. Syndrome means a group of diseases or a group of condition which together manifesting the problem. That is called syndrome. So here in the medulla oblongata, that too in left lateral side is more dangerous than when comparison to right side of the medulla oblongata. So here first we need to know the MRI scan. We need to thoroughly understand the MRI scan. After that, we need to understand that pharyngeal status. If there is any secretions, is there any vocal paralysis or phonatory gap, or how the pharyngeal tone is there. So we need to understand first of all that, and then we need to insert the treatment protocols.
Very nice, sir. And now I hand over this to our Premnath sir.
One second, sir. Pooja, you have asked question regarding the book, right? So I'm showing a book here. You can see write down here. This like dysphagia, clinical management in adults and children. Okay. This book is given by Michael E. Grofer and Michael A. Crary, PhD. So this is a very excellent book. You can find out this. Okay, it's available. If not, contact me. I'll give you this book so that you can get it. It's a very nice book, clearly explained. Okay, sir. Yeah, thank you.
Then see, participants can also keep the videos on so that it will be nice interacting. Any other question? Last question, so that we can conclude the session. And I request Premnath sir to be ready for the conclusion.
Yes. Anyone left over with the questions? So let me conclude.
Yes, sir. Please carry.
Okay. Thank you, all the resource persons, including me. First of all, thank you, organizers. Okay, thank you, Professor Dr. RKP as a host, and our Honorable President, Dr. Nagendra Garu, and Honorable Secretary, Dr. Imad Khan Garu, and presenters, our Honorable EC Member, Dr. Gangaraj Garu, and Honorable EC Member, Dr. KV Garu. Excellent presentation, excellent scientific webinar it went on. And hopefully we have cleared, we all together have cleared many doubts and meaningful discussions went on. Okay, thank you one and all in participating and make it very successful.
Sir, thank you very much. And I also thank our assistant director, guest of honor, and also our chief guest, Dr. Nagender, and who is the president and the general secretary, Imad Khan Ruman, and our EC members whole, and also the participants who have actively participants like Aruna, Pooja, and some other people from other state, even that is from Delhi also. So all over 100 participants have participated actively, and a few of them have shown very much interest. And though for the technical reasons, I please regret the technical issues which are there. And apart, though it was there, all of you were intact with the lecture. And thank you once again, all of you, and our assistant director Srinivas sir, and all the dignitaries who are present attended this webinar. And we thank to all the speakers once again. And in the near future, we will come up with some more webinars which are more relevant and occasional, and as well as important one for all of us. Thank you.
Thank you,
Jai
sir.
Hind.
Professor RKP, sir, your questions are like rapid fire, fire on fire. But our Premna sir and our KV and our Jangaraju handled all the questions very well. I'm really proud of them, especially Dr. Premna sir. We all can understand how difficult it was for you to present without proper ventilation and lighting. But in spite of that, you managed very well. And Dr. KV also did wonderful job. Within real time, he showed the reference, book reference. And our Jangaraju also did wonderful job, though it is a first time presentation. He did excellently. And in the beginning, I thought to share one screen, sir. At that time, there was a technical issue. Shall I share, sir, that screen?
Yeah,
please.
Start. 1 minute, sir. Photo. Gallery. Can you able to see this, sir, now?
Yes, it is showing.
This is the Swallowing Awareness Day. I just got it from one Australian website. So here the points what I told. People swallow 700 times per day, and humans swallow once per minute while awake, and around 3 times an hour during sleep, and even more during meals. 1 in 17 people will develop some form of dysphagia in their lifetime. Swallowing uses 26 muscles, and more than 1 million Australians have difficulty swallowing. I think Australian population is around 2.5 crores or 3 crores. Compared to that, in India, we have so many millions of people who are suffering with this dysphagia problem. So a swallowing disorder may affect 15 to 30% of people aged 65 plus living in the community, and it will also affect 50% of older adults in nursing homes, 84% of the people with Parkinson's disease, 100% of people with Alzheimer's at some point in their disease progression, 20% of adults with mental health disorders, 45% of patients with head and neck cancer post chemo radiotherapy, 40% of stroke survivors have an ongoing need for support for swallowing, 25% of patients with multiple sclerosis have swallowing difficulties, increasing to as many as 65% of those with severe multiple sclerosis. This is all the summary of the Swallowing Awareness Day and how the people are suffering with these problems.
Okay, very nice.
Thank you, sir. And our Dr. NMS Reddy is also joined, sir.
What is going on in general hospitals and general scenarios, sir? See, patient treatment success, but patient died. Why these things is happening? Why? Because all of they are only primarily focusing on that medical symptoms. After the medical treatment and the patient get the stabilization, then we need to focus on the most important area following. So the malnutrition and the aspiration is causing more deaths. See, the severe cause of aspiration leads to death, and moderate to moderate severe cause leads to ICU admission, and the mild to moderate cause leads to aspiration pneumonia and dehydration, some other things. So I kindly request the people, please take the ASLP assistance and overcome these problems.
Okay. Sir, may I request one group photo, sir?
Yeah, sure.
Yeah. I request everyone to switch on the videos. Please switch on your videos. Yes. Sir, RKB sir, can you take group photo from your laptop?
No. I'm from mobile. I'm actually accessing.
Mobile. No? Okay. I am taking screenshots. One. Yabba, Lakshmipati. Wow, Premna sir, now you are looking perfect, sir. Somebody mobile is ringing.
Seeing this photo, all
Raja,
young, dynamic,
Dr. Vikrant's iPhone, please switch on your videos.
all young dynamic people are there. Like Dr. Arif, Dr. Jyoti,
Dr. Gopi from AP,
Dr.
please switch on
Reddy.
your video. Dear
Everyone.
Honorable General Secretary of AP ASLPA. Dr. NMS, you want to add any points?
Very nice.
Dr. NMS, please add your points. Unmute, please unmute first.
Good evening, all. Wish you happy Swallowing Awareness Day to all. So such a nice presentations. All areas, like all celebrations we are celebrating today also. We did not miss the Swallowing Day, Awareness Day, with nice adding of anatomy, basic things of anatomy, physiology, case presentations, such a nice. Even I learned few things. Even we are not that area, but baseline of that, every individual presenter today presented well. Yeah, thank you so much for conducting this kind of awareness day, such a nice topic presentations. Thank you so much, team TASLPA and Yuka. Thank you, sir, for giving this opportunity.
Sure,
Thank you.
Dr. Namesh Reddy. Thank you for your comment. Next, in future, we will come with more standard type of presentation. And this is a very premier topic, which is a very demandful topic all over the world for all the ASLPs and speech language pathologists especially. So we will, in future, with our team, we will have one more, this one in coming future in any other occasion or some other day, with help of our team TASLPA and Yuka. And with this, let's conclude this session.
Yes,
thank
sir.
you. And I have to thank our
Professor
Dr.
RKP, sir.
Arif for designing the PPT from our Dr. Gangaraju side.
Great.
And I also thank our Dr. KV Narayana for presenting very nicely. And I also thank all the our Premnath sir, who was very much what we call active member, who tried to do it from the front. And from yesterday, I got this job suddenly, so I have taken up with the help of Lord and with everybody's participation. 100 people have participated. That is houseful. This is a record, which is again repeated in TASLPA.
Repeated second time houseful, sir.
No, definitely a big clap for that.
Yes, it's all blessings of Lord. Everyone, I thank everyone like Lakshmipati sir, whoever seen here, Aruna madam and Murali, everyone, Ankita Moria and Gopi Venkatesh from AP, everyone for actually participating and motivating us. Tomorrow, in coming future, with the help of our dynamic president and general secretary and treasurer and every EC member and past EC member, we will come up with many more activities. Thank you. Jai
Yes,
Hind.
sir. Thank you, sir. Thank you, sir. I'm ending meeting
Thank you
for
so
everyone.
much, sir.
Bye.
Thank you.
Thank you. Sir, Premna sir.
Yes.
ఒక్కసారి జై తసల్పా చెప్పండి సార్ మీ నోటితో.
జై TASLPA, జై TASLPA.
Thank you, sir.
Jai TASLPA,
Jai TASLPA, Jai TASLPA.
Bye.
Okay.